Good afternoon, everyone. Today we are going to discuss pediatric urology FRCS Urol Viva practice. So this is in itself a table where two sessions will be discussed at a stretch for continuous 20 minutes. It could be either two scenarios 10 minutes each, or it could be multiple scenarios over a period of 20 minutes. Today we will discuss such a session so that you will get that feel of the exam. So we will start at 10 minutes, and then when the bell rings at 10 minutes time, we will change the scenario and go for a new scenario for the next 10 minutes. I hope that's all right.
Yeah, thank you.
Thank you. So I'll start the timer now and we shall discuss the first scenario. So your time starts now, and you are in the pediatric urology table. This clinical scenario is you are doing a pediatric urology clinic. A 2-week-old infant is referred to your clinic with an ultrasound diagnosis of left hydronephrosis. This was picked up in an ultrasound scan during the 3rd trimester when the APR diameter was 5 millimeter, and the plan was to repeat the ultrasound scan 2 weeks after birth. How do you want to proceed?
So I review this neonate with his parents in the pediatric clinic. I will make sure that I will review the records of the antenatal ultrasound. I will take a brief history about the delivery and about well-being of the child, about his feeding, whether he's opening his bowel or not, passing urine with difficulty or not, any fever or rigor, vomiting during this period. I will ask also about any similar problem in the family, about the order of the baby in the family, and also I will ask about any drug allergy, the use of any medication during this period, and then I will proceed to examination in the presence of chaperone. I'll examine the child weight and height. I will compare it to the chart, and then I will examine his tummy, looking for any palpable mass in the loin or tenderness in the loin, any palpable bladder. I will examine his genitalia, and I will examine the back also, looking for any abnormality in the spine or any dermatological findings suggestive of spina bifida, and I will check the lower limbs as well. After that, I will proceed to arranging a urine test, urine dipstick of a clean catch urine, and I will arrange for a repeat ultrasound as a follow-up for his left hydronephrosis.
Well done. So what is the nice recommendation on the timing of antenatal ultrasound scan?
So usually the anomaly ultrasound will be done at 20 week. And if there is any abnormality related to the urinary tract, then we need to repeat the ultrasound again at 28 week of pregnancy.
Okay.
And then after delivery, usually we delay the postnatal ultrasound for up to 2 weeks. However, if there are certain indications like bilateral significant hydronephrosis or hydronephrosis on solitary kidney, or quite severe hydronephrosis with renal pelvis diameter more than 15 millimeter, then I will arrange for an urgent ultrasound after delivery as soon as possible.
Okay. In the ultrasound scan at 28 weeks antenatal gestation, what are the things that you look for in the ultrasound scan?
So I'm looking for any degree of hydronephrosis, and to measure the AP diameter of the renal pelvis at the level of the renal hilum. I will look for any dilatation of the calyces, any cortical thinning, also whether there is any dilatation in the ureter or not. I will look at the shape of the bladder, if there is any thickening in the bladder wall, over distended bladder, or the bladder is never full, as in the case of bladder atrophy. Also look at the genitalia to see whether he is a male or not, and also assess the degree of oligohydromenous or anhydromenous.
Can you mention about one system, one grading system that is used to grade hydronephrosis and
Yes, I am aware of the Society of Fetal Urology grading system, which composed of 4 grades. So in grade 1, there is a mild dilatation of the renal pelvis. Grade 2, there is some dilatation of the renal pelvis with dilatation of the calyces. Grade 3, there is a significant hydronephrosis, dilatation of the renal pelvis and dilatation of the calyces as well with some cortical thinning. And in grade 4, there is bilateral hydronephrosis.
Okay. What is the most common pathological cause for neonatal hydronephrosis?
The commonest cause is PUJ, which is in about 14 to 15% of the cases, followed by VUR in about 12% of the cases.
Okay, so this child is feeding well, urine output is normal, no palpable abnormalities on examination, and there's no significant family history. How do you want to proceed for him? It's male child.
Yeah, so my understanding is that the prenatal ultrasound showed some hydronephrosis on the left side. So as I mentioned, I will arrange for Undescended. I will do a blood test to check his kidney function, and I will arrange for a repeat ultrasound to confirm whether the hydronephrosis on the left side has been resolved or not.
Okay, so the repeat ultrasound scan again shows the hydronephrosis is persisting. There is dilatation of the left pelvic calyceal system and the ureter up to the level of the bladder.
Okay, so in this case, I need to arrange for MCUG, micturating cystourethrogram. So I will explain the finding to the family. I will start the child on a prophylactic antibiotic, trimethoprim, 2 milligram per kg, single dose. And I will arrange for micturating cystourethrogram. At the time of the MCUG, I will give the patient a treatment dose of trimethoprim.
What are your differential diagnoses at this point of time?
So since there is a dilatation of the ureter and the renal pelvis, then we are thinking about a mega ureter, which may be refluxing or obstructing.
Okay. So your VCUG shows that there is no reflux into the upper tracts.
Okay, so in this case, mostly we are looking for obstructing megaureter, which may happen due to a peristaltic segment at the VUJ.
Are there any other investigations you would like to do?
Usually the MCUG should exclude the reflux, and I will assess the diameter of the ureter. Ideally, it should be, if there is a megaureter, it should be more than 7 millimeter in diameter, and I will make sure that the child has no infection. I can also arrange for a DMSA scan to check the function of the kidney, separate function in the kidney.
Okay. So, what is the classification of megaureters?
So classification of megaureter is either refluxing, which is vesicular reflux, or obstructing, or non-refluxing, non-obstructing.
Okay. Any subdivisions for that?
I think it is a primary or secondary. Secondary could be related to bladder outlet obstruction, as in neuropathic bladder or peripheral valve, or it is a primary. When it is a primary, we divide it either it is refluxing or not, and then if it is not refluxing, it could be obstructive or non-obstructive.
Okay, so your child had this MAC3, which shows that there is delay in the drainage from the left kidney. The differential renal function is preserved at this point of time, 45% for the left kidney. How would you like to proceed from here? The child is asymptomatic otherwise and is on prophylactic antibiotics.
Since the child is asymptomatic and there is no significant difference in separate renal function, I will continue conservative therapy, as most of the time this narrowing at the lower ureter may be resolved spontaneously. So I will review the patient again by having a serial ultrasound every 6 months, checking his urine and kidney function. And then I will continue the antibiotic usually up to 1 year. If there is no infection during this year and there is no further deterioration of renal function, then I will see the child less frequently following that.
Okay. What will be the indications to go for a surgical intervention?
So the main indication is symptomatic in the form of recurrent febrile UTI. Also deterioration in the septal function. So if the septal function initially less than 40%, or there is a further deterioration by 5 to 10% in the follow-up, and also worsening in the degree of hydronephrosis.
Well done. So it is 10 minutes now. So we will go to the next scenario.
Yes, please.
So in this case, you are on call, urologist, and you are called into the birth suite, and they are concerned for a male boy with right undescended testis. What are your thoughts and how would you proceed?
Sorry, how old is the boy?
Neonate.
1 month.
Sorry, you are called into a birth suite. So it's a delivery suite.
Delivery
suite. And there's a newborn with the left testis is palpable, the right testis is not palpable.
Yeah, so I will go to review the child myself. I will take a brief history about any known antenatal problem during the pregnancy, about the order of the child in the family, and a similar problem in his sibling or in the family. And then I will proceed to examination in the presence of chaperone. I will examine the child weight, height. I will examine his abdomen, looking for any associated anomalies. And then after that, I will examine the groin, looking for any palpable testis or mass. And then after that, I will have a look on the scrotum to see whether the scrotum is well developed on that side or it is shallow. I will also inspect the other normally descended testis to see whether it is larger in size or it looks normal in size. And then I will start in a warm room with warm hand. I will start trying to palpate the testis at the groin and try to milk any palpable testis down to the scrotum with 2 fingers.
Okay.
I will also examine the base of the penis, the perineum, as well, looking for any ectopic testis, and I will examine the perineum and the back for any associated anomalies as well.
Okay, so this child is otherwise fine, except for the right undescended testis, which is not even palpable. The left testis is normal in size. Scrotal rugae underdeveloped on the right side, and you examine the ectopic side, that's also normal. What is the incidence of undescended testis at birth?
So the incidence at birth in a full-term baby is about 3 to 4%, which reduced down to 1% by 3 months of age. For the low birth weight or premature baby, it is about 30%.
Okay. So what is a nice recommendation on the initial monitoring of this child?
So usually we allow a time for the testis to descend by itself. Usually if the testis is not descending by 3 months, then it's unlikely to descend. And according to the NICE guideline and also the British Association of Pediatric Urologists, it is recommended to consider orchidopexy early in life between 6 to 12 months.
Okay. What is the reason that orchidopexy is recommended before 12 months of age or around 12 months of age?
It's mainly related to the future impact on infertility, because the neonatal gonocyte will be changed into the adult dark spermatogonia between 3 to 12 months, and this step is important for preserving future spermatogenesis in the child. Therefore, it is not recommended to leave undescended testis more than 12 months.
Okay, so you reviewed the child at 6 months' time, and then at that time also the testis is not palpable. They couldn't find the testis even during warm bath. How would you like to proceed from here?
So I will explain to the family that we need to look for the testis first. So I will examine the child again at the age of 6 months to see whether I can palpate the testis or not. If the testis is palpable, then I will arrange for right inguinal occultopexy. If the testis is not palpable, then I will arrange for examination under anesthesia plus minus laparoscopy.
Okay. Will you give them any information leaflet?
Yes, I will support my counseling by giving the family the BAU's specific information leaflet for the procedure. I will explain that occultopexy is a day case. It will be done through an incision over the skin crease in the inguinal region, and we try to bring the testes down into the scrotum by creating a subdartus pouch. I'll explain about the common complication of infection, pain, bleeding, and about possibility of testicular atrophy later on, which is about 3 to 5%, and the low possibility about 2% with testis ascending upward again in the following years.
Okay. Will you do any imaging investigations before the diagnostic laparoscopy in an undescended testis?
Usually we don't do any imaging because it is difficult to localize a small undescended testis by ultrasound, and an MRI scan most of the time it will require a general anesthesia, which put the child at increased risk from general anesthesia. So I will just proceed with occultopexy if the testis is palpable in the groin.
Okay. Going to the embryology, what are the factors that help with testicular descent?
So testicular descent will happen in 2 stages. Stage 1 at the age of 10 to 15 week, where the testis descend from the genital ridge down to the internal inguinal ring, and this is triggered by thickening of the gubernaculum, disappearance of the apical suspensory ligament, and also by hormonal factor including mullein inhibitory substance and insulin-like factor 3. And the second stage will happen at the age of 25 to 30 week, mainly triggered by shortening of the gubernaculum and by the processus vaginalis, and also hormonal factor which include testosterone and some neurological factor including the calcitonin gene-related protein from the genitofemoral nerve.
Is there any role for medical management in undescended testis?
No, actually, a few studies have reviewed the role of medical treatment in the form of human coronary gonadotrophin or gonadotrophin releasing hormone stimulation, was shown not to be effective in case of unilateral undescended testis to bring the testis down. However, it may have a role in patients with bilateral undescended testis to augment fertility later on.
Okay. What is the risk of malignancy in undescended testis?
So undescended testis is known to be associated with increased incidence of testicular cancer, and about 5 to 10% of all testicular cancer occur in undescended testis. However, we have evidence from studies showing that if occultopexy done early in life, this may reduce the risk of testicular cancer. So if the occultopexy is performed before the age of 6, then the risk of developing testicular cancer is about 2.5 fold compared to 5 to 6 fold if the occultopexy is performed after the age of 13.
Okay. What is the risk of testicular atrophy after orchidopexy?
So after inguinal orchidopexy, the risk is about 3 to 5% only.
Okay. And what is the risk of orchidectomy?
The risk of orchidectomy is quite low. The testis, if a good size, good shape, will do orchidopexy. So the risk of orchidectomy, I think it's less than 5%.
Okay. The mother is asking, what about his fertility potential after unilateral undescended testis repair?
So usually the fertility is well preserved if orchidopexy performed early in life and it is unilateral undescended testis. So the fertility potential is similar to the general population, which is around 90%.
Okay. So you did the procedure under anesthesia. You could not feel the testis even under anesthesia. You are proceeding with diagnostic laparoscopy. You can see the testis near the deep inguinal ring. What will be your approach now?
So in this case, I will try to push the testis into the inguinal canal, and then I will change into an open inguinal incision and perform orchidopexy. If there is a shortening of the cord, I will try to do Fowler-Stevens, and I prefer to do the two-stage Fowler-Stevens.
I'll stop there because in exam, definitely after the bell rings, it is stopped. So that's why. Sorry. So I'm just trying to give that feel of the exam itself. That's why. Sorry. I hope that's all right. I'm not. I doesn't mean to interrupt, but this is what happens in exam.
Yeah. I couldn't. I was speaking. I couldn't hear the bell. Sorry.
I don't mean to be rude, but as soon as the bell rings, that is it. So we stop the discussion. But So are you all right for the feedback?
Yes, please.
Okay. So what do you feel about? So we'll go with the antenatal hydronephrosis. What are the positives?
I think it was a straightforward. Maybe I'm just troubled a little bit about the classification of megaureter.
Yeah, because I had the same scenario and the same question was there. So it is called the initial classification, the refluxing, obstructed refluxing, non-obstructed non-refluxing. It is called the Smith's classification.
Okay.
And that was modified by King into primary and secondary.
Okay.
The main implication of that is in the management. And there were no concerns, all the numbers, the management. There was a slight prompt needed for the renogram, but otherwise, so always it is ultrasound scan, repeat ultrasound scan, then our differential diagnosis mainly to rule out VUR. As you know, 15% of PUV can present with unilateral dilatation only. So to rule out all these things, we will do MCUG, VCUG. Then if that is normal, our differential diagnosis will narrow down to either obstructive megaureter or even ureterocele with a duplex kidney and obstruction, things like that. And once we diagnose that it could be most possibly primary obstructive megaureter, then the next thing is what we are going to do with that one. So that's where the role of renogram comes, because we had to have a baseline and then we had to serially follow up. And if it is more than 5% deterioration in the differential renal function, because that is an indication of surgical intervention according to BAPU 2014 guidelines.
Yeah.
I think that went well. I went in depth regarding the investigation part. Most of the time this will, if there is 1 more minute, the question will move on to the surgical options and the different types of extravesical, intravesical reimplantation, and also regarding the minimally invasive things that we do until the child is mature enough to have a procedure.
Yeah. So I think we will try first the stent, since if there is no infection, no significant duration, we'll try first the stent, which may solve the problem. If not, then we'll move to the reimplantation.
Yeah, and that's a question. What you try to put a stent, not working, what you're going to do? So in that case, we can do a refluxing anastomosis. So because the ureter is dilated, so that you can anastomose the ureter to the bladder, but it will be a refluxing anastomosis. And once the child is mature enough to have it under general anesthesia, then you can do the ureteric reimplantation.
Yeah.
And the questions will be like, what are the different types of ureteric reimplantation that you know of? Then the extravesical and the intravesical. And sometimes if again, I mean, the questions can be regarding the tapering, the different types of tapering. So, and also the different names of the procedures, extravesical, intravesical. I think the most commonly used one is intravesical Cohen's cross trigonal, and there is also Politano Ledbetter, and the extravesical one is the Lischgruger.
Yeah.
Brilliant. There's no concerns. Otherwise, you answered all the questions well. Sometimes, I mean, as you already know, there will be more questions than the discussion for 10-minute session. And sometimes, if you are doing really well, the examiners can skip and go to the last questions.
Okay.
I will try to do it next time, and if the discussion is going well, I'll go to the end of the scenario quickly.
Yeah, very good.
What about the undescended testis positives?
I think positive about the descent of the testis, the stages of descent.
So from my side, I mean, everything was fine. I haven't written anything negative on that part. It all went well. No prompt needed. Even for when I discussed about the embryology, you brought in all the factors that are important for the testicular descent. All the hormonal factors, neurotropic factors, the INSL3, all those were mentioned. So no prompt needed. So that's how one of the advice given is you have to talk for at least 40 seconds for each question.
Yeah, so definitely. That's a good advice.
Yeah, and you did well. A couple of things that would have been discussed over. I mean, that is part of the examiner's aspect as well, because I discussed more regarding the initial part, how the investigation things and all. Sometimes it can skip through and directly go to the surgical option, Fowler-Stephen. Only one caveat, I persisted on the information leaflet because the Bow's information leaflet says that we will do an MRI scan before the diagnostic laparoscopy, but not necessarily. We all know that. Because as you rightly said, because MRI scan will need a general anesthetic in that age group, so the sensitivity or accuracy is more with diagnostic laparoscopy, and it is diagnostic and therapeutic as well.
Yeah, so, exactly.
I just want to bring that point only. But you can say that we'll give the Bow's information leaflet and then proceed. And if the question comes regarding the imaging, we can say that it is not recommended.
Okay.
I think otherwise, I think that was, Then my final question was, once you answer the Fowler-Stephen stage 1, stage 2, or sorry, 1 stage or 2 staged, then the question is regarding any other surgical options, and the answer for that is microsurgical autotransplantation, but it needs skilled and experienced surgeons.
Yeah.
One question that can be asked is, what if there is a late presentation? That can ask in a clinical scenario where the parents are vagabond and they presented to GP and the child is like post-pubertal and there is undescended testis on one side, and it is the inabin is palpable in the inguinal region. What will you do?
Yeah, there was some debate about this question in the BAPU course that I attend.
Okay.
Because I think most of the guidelines is since after the age of 13 is to perform ochiectomy. However, few of the pediatric urologists, they are saying no, you can just do orchidopexy and observe the testis.
For that one, I think you have said the right answer. According to the guidelines, the recommendation is orchidectomy because of the presence of GCNIS of around 2%.
Yeah.
I think we can answer it like that. According to guidelines, we have to, whenever there's a controversy, we can stick with the guidelines and nicely say that there are that topic is still controversial.
Yeah, exactly.
So we will do one more session like this. So this is a field that you get continuously speaking for 20 minutes.
Yeah, yeah.
And you have to, as I said in the morning session, energy, top level of your energy from the time it starts to the time it ends at 20 minutes. So pediatric urology is 20 minutes continuous.
Yeah, yeah. But it seems when you are progressing well, it seems like 5 minutes actually.
Exactly. And you did well on the undescended testis. There was no prompting needed. All answers were flowing. So that was a good session.
Very good. Thank you very much.
Brilliant. We will discuss one more scenario later. I will arrange that and then I'll update you.
Very good. Thank you.
Thank you so much and good study. I'll see you later.
Have a nice evening. Thank you very much.
Thanks. Yes. Bye-bye.
Bye.